Right, it was a very important evening. Yes, of course, birthday, Founders Day, it's significant for the academy. But today's celebration was totally the highlighted by Dr. Darshana's presence and her address. Uh, the way she could, not just inspire, you can transpire. Okay, so that way, how she can evolve her inner energy to, of course, everyone who is listening. So it was a fantastic experience. Our committee members like Dr. Debangshu was asking, last time we saw Dr. Darshana in the celebration, so how is she? So I was unable to answer because she did not make a public appearance, okay, all these months. But today, she took a step and she was there when the celebrations were going on, and it was absolutely, I can say that it's one of the most special moments of life when you can see such a great personality, a learner par excellence, is back on track. And whenever you have cerebral venous thrombosis, okay, it's a venous type of stroke. All the sinuses there were thrombus except the cavernous sinus. Okay, so it's very, very tough. Okay, it's an amazing magical transformation which is superhuman. Okay, it is impossible for anybody to even imagine and speak like that theoretically also. Okay, but she has done it in her life and she has lived through all the challenges, and she is back as the Darshana whom we all know. I will share that video, of course, with all the members on the WhatsApp. And yes, of course, the model boy who's supposed to reach here is a bit delayed because of his exams. So he will be coming after that. So he is expected to reach around 5:15. So meantime, it's always good to be a pathomechanics oriented discussions, especially with the knee ligament injuries. That's something which is more common in our practice, and we have maximum ligaments in the knee, and some injuries happen together and some injuries happen isolated. Some are called as instabilities, and of course grade 1, grade 2, grade 3 ligament injury classification, which the world is very familiar of. But the most important factor here is the pathomechanics in terms of the kinetics and the kinematics. So which muscle contractions will be agonist or the synergist or antagonist to the ligaments, each of the knee ligaments. In kinematics, we will rather think of what is the actual movement related mechanism which actually can strain the ligament and lead to an injury, and how this unidirectional and multidirectional instabilities influence the patient's functional performance in our activities and also maybe in some of the sports. So knee ligament injuries and their pathomechanics. So that is something which is very, very biggest topic. And when it comes to post-operative recovery and rehabilitation, it is another totally a different, bigger dimension. Because the injury happening due to nature, accidents, trauma, atraumatic, it's all fine. But the post-operative is iatrogenic. And be it the surgeon, be it the type of the reconstruction or the grafts, be it whether it is arthroscopic or it is open surgeries, be it primarily the ligament injuries or it is whether it's part of the knee replacements, where during a replacement you can have a ligament being spared or ligament may be again reconstructed together. So there are a lot of options. Yes, ma'am. Video, audio, everything is fine.
Yes,
Ritu,
sir.
ma'am?
Perfectly fine.
I do not know. Sujanya was not able to join. I gave her the invite. So this is actually a bigger picture, and we always see that adhesions are common between these ligaments, capsule, multiple tissues that are there in different layers. We might think it's only the flexion extension that is available in the knee, but there is a valgus varus force and there is internal external rotation of tibia. And to make it more interesting, the patella is also there. Okay, so the knee mechanics is the best actually for biomechanics itself. And when you see knee ligament injuries, we had a course, ligament injury course separately, specialist course, of course, different ligament injuries, different regions. We had 10 topics and we covered them in pathomechanics and also manual therapy. Of course, but today's session is exclusively dedicated to the pathomechanics, right? So I'm just looking forward to Ritu ma'am again reconnecting. Okay, is it my side internet? The viewers who are joining, can you just post in your comments whether my audio video is clear? So I continue.
Yeah.
Right? Yeah, Ritu ma'am.
Yes.
So Sujanya is not able to join. I have given, this is the third time I am giving a request. Okay. To name the ligaments, first see knee joint in neutral. Okay, you can classify them into patellofemoral ligaments and tibiofemoral. If patellofemoral you want to see that, important ligament is the ligamentum patellae. In the name it is a ligament, but it is embryologically it is actually a tendon, the quadriceps tendon. But anatomically we divide here into quadriceps tendon and this becomes a patellar tendon, which is otherwise called as the ligamentum patellae. Okay. So these injuries usually are called as patellar tendinitis rather than ligamentum patellae strain, ligamentum patellae grade 1, grade 2, grade 3 injuries. No, we do not tell that. Okay. So imagine that it is actually a tendon and this is the sesamoid bone there inside. The next one in patella is the lateral retinaculum, the fibrous expansion here, and the medial retinaculum, of course, as per their anatomical locations. Meniscus, we have lateral meniscus and medial meniscus. Both of them have meniscopatellar ligaments. This is a direct relationship with rotational forces, shock absorptions, where meniscus and patellar rotations, okay, they will happen synchronously. Let me just give a try to approve Sujanya. Okay, yeah. So patella, another one is of course the synovial membrane folds are there. These folds are called as the plica. So there is medial supra, medial and medial infra synovial plica, infrapatellar plica. Okay, medial. The plicas are thickening of the synovial membrane, folded, and they also again added strength to the synovial membrane, and they get unfolded whenever you need an extra space for the movements. So that is again, it is actually working like a bursa one side and ligament another side. Okay. And then the next one you see, bursae is also present around the patella, but they are all mostly the direct impact. So they all work passive structures. Okay, so they again come under the ligaments. If it is muscle contraction and beneath the muscle, if bursa is there, like tendoachillis and retrocalcaneal bursa, so we'll include the bursa under the tendon because contraction will influence the bursa. Same like supraspinatus contraction and subacromial bursa. But if it is independent of the muscle contraction and direct compression only will affect the bursa, it's a passive structure, the bursa is. So there we consider it as an extension of the synovial membrane or as an extension of the capsule, that is the bursa. It can be intracapsular bursa or intra-articular bursa. So different aspects you can focus, and although the term is bursitis that comes, you can also have that bursitis due to a bursal tear. Okay, so that can be synchronous to the ligament injuries. Okay, especially bursa of an elderly, where you have less synovial fluid within the bursa. So it becomes more like a fibrous structure, like a ligament. Okay. Same like how a calcific tendinitis comes. Because calcific tendinitis do not come in the knee, but when you see otherwise, a calcified tendon cannot be influenced by contraction. It can be influenced only by direct compression. Okay, so it becomes a passive structure rather than a tendon being an active structure. Okay, just let me check whether the boy is around. Okay, we are expecting anytime he can reach. Okay, if you hear the bell ringing, and if the session is disrupted, definitely Ritu ma'am and other members who are enrolled for the evening practical webinar, osteopathy and the chiropractic manipulations, could join me in the Zoom link, which is already shared in the group. Okay. So until then, we'll just continue this. So coming to the tibiofemoral ligaments, absolutely the capsule is definitely the biggest ligament, and beyond that, it's the medial collateral ligament, lateral collateral ligament. Meniscus, it's a fibrocartilage, but again, it is a passive structure for compression and also stretch. So that also is included under the ligaments. And the meniscus, which is here to the tibia, is attached to the tibia with meniscotibial ligaments, and meniscus is attached to the femur with meniscofemoral ligaments. Both are there. And when you come to the tibial plateau, the center, you have the cruciate ligaments, which is more like the anterior cruciate runs from the femur towards the tibia like this. Posterior cruciate exactly 90 degrees opposite to the anterior cruciate. It goes in the posterior direction. Both are intracapsular, but they are extra-articular. They are not inside the synovial membrane. They are not in the synovial fluid. They are just inside the capsule. And posteriorly, the cruciate ligament, posterior cruciate, has two ligaments medially, two ligaments laterally. The two ligaments medially is called as the ligaments of the Humphrey and Risberg. And the two ligaments which are laterally is called as the arcuate popliteal ligament and oblique popliteal ligament. So in Tamil movie Rajinikanth, there is a movie called as Basha, where Rajinikanth walks in the center and there are two people right of him, two people left of him. Same like that, here there are two ligaments to the lateral side of the PCL and two ligaments the medial side of the PCL. Okay. So, of course, whenever we talk of the support for the PCL, you should think in terms of mostly whether the hyperextension, okay, or rotations, that will influence whether the medial two ligaments will support the PCL or the lateral two ligaments which will support the PCL. And of course, other than this, as of now, we are fortunate that there's not much any ligaments. But sometimes, very rarely, the gastrocnemius heads are there from above the femur. So that can have sesamoid bones, which is accessory bones, called as fibula. F-A-B-E-L-L-A. Fibula. Okay. So that fibula is an accessory bone. It's not present in everyone. It may be present on 1% or 2% of individuals. So that fibula can have additional fibrous attachments, and you can have anomalies, developmental anomalies of various ligaments that can be there. Fibulofemoral, fibulotibial, okay, ligaments. Okay, so that is again another picture. As you see the iliotibial band which comes to the lateral part, the Gardy's tubercle of the tibia, okay, laterally that is there in front of the fibula, okay, the Gardy's tubercle. That is the attachment of the iliotibial band. Whether iliotibial band can come under ligament, it's a huge controversy, but it's a fibrous band mimicking like a ligament only, but it's much more thicker, much more longer. It is not an active structure, it cannot contract, okay, itself. But the tensor fasciae lata which is here becomes iliotibial band from the greater tuberosity, okay, of the femur. So that is like a more of an extension of the tendon of tensor fasciae lata. Okay, so get to see that the difference, how you can highlight, okay, and the next of it is of course the various structures are attached to each other. Some structures are separate, like lateral meniscus, which is separate. Except attachment of tibia and the femur, there is no attachment to the lateral meniscus. But whereas you see that the anterior cruciate ligament itself has attachment with the meniscus, okay, at the tibial plateau. Okay, here the meniscus is also, it is attaching, and medial capsule and medial collateral ligament, they both are attached with the medial meniscus also. Okay, so which we call it as various conditions. Okay, it may become a complex injury, because if one injury is neglected, it will lead to the other structures also getting injured eventually. Mostly in sports it happens because the athlete actually wants to get back into the game, so the trainer or the therapist puts some protective device, taping, and gets the patients or the clients back on the field, which again the game situation and the challenges will force another injury, and also recurrent injuries, okay, re-injuries will come as more chronic and functional instabilities. So that is about the overview of the ligaments in the knee joint. And what I want you to understand is, when we talk about this kinetics, for example, what is the role of the medial collateral ligament, okay, versus the medial capsule? Very simple, both stabilize against the valgus force or abduction of the tibia. Or when tibia is weight bearing, adduction of the femur, okay, adduction of the femur will also cause the valgus, the same medial opening lateral compression. So both are tackled by the medial collateral and the capsule. The next part, when you see how do you differentiate these two, if the knee is fully extended, capsule will stabilize against the valgus. Whereas if the knee is slightly flexed, it's in the loose packed position, 15 to 20 degree flexion of the knee, then the valgus force definitely will be taken over fully by the medial collateral ligament. So you need to differentiate these two. Valgus test of the knee, you are supposed to perform in full extension, you are supposed to perform in 20 degree knee flexion. Okay, both are to be done. And medial collateral ligament, the direction of fibers from the medial epicondyle of the femur to the medial epicondyle of the tibia, the fiber actually comes anterior like this. Okay, so because of this reason, it also stabilizes against an external rotation of the tibia. Note down, those who are regularly attending my pathomechanics webinars will understand that whenever I talk tibia movement, it is open kinematic chain. Whenever I talk of femur movement, it is a closed kinematic chain. So either it is the external rotation of the tibia, the medial collateral ligament will stabilize, or internal rotation of the femur, the medial collateral ligament will stop and stabilize. Okay. Let's see if Sujanya's net is better. Okay. And that's about the rotation component, other than the frontal plane component. Okay. So internal external rotations are transverse plane. A valgus is a frontal plane or coronal plane. And also medial collateral ligament is angulated like this. So if I have to keep my little finger, medial collateral ligament is like this. Okay. So easily you can all guess what will be the added function of the medial collateral in the sagittal plane. That is an anterior translation. Okay, so it will stabilize against the anterior translation also. So one ligament, medial collateral ligament, it can function in all the three planes. So that means one is the valgus force in 15-degree knee flexion, loose back position. Okay, not the full extension. 15-degree flexion, you give the valgus force. So that is medial collateral ligament. Second is, it comes from posterior to anterior. So it will stabilize against the external rotation of the tibia. And the third one is the anterior translation of the tibia. All these are open kinematic chain. If you want that closed kinematic chain, it's the reverse. So that means instead of external rotation of tibia, tibia is fixed. Internal rotation of femur will create the straining of the ligament. Remember, when I say the collateral ligament stabilizes against rotation, then that means the rotation will strain that ligament also. It's the same. Okay. And so that is internal rotation of the femur. Okay, in the closed kinematic chain. And then as abduction of the tibia, which is open kinematic chain, where the foot is free. Okay, abduction of the tibia. So that also will injure the medial collateral ligament. Otherwise, the foot is supported and adduction of the femur will also open the medial collateral ligament or strain that ligament. So adduction of the femur. And the third component, where anterior glide of the tibia I said for open kinematic chain for MCL, posterior glide of the femur in the closed kinematic chain can also strain the medial collateral ligament. But the only difference is the part, the femoral part versus tibial part. Because ligament is like this. But you can see before my interphalangeal joint is the femoral part. After the interphalangeal joint is the tibial part. Tibial part will get injured with the movement of the tibia, and femoral part will get injured with the movement of the femur. And whenever we talk movement of the femur, it is the closed kinematic chain. Movement of the tibia is the open kinematic chain. So as I was discussing only for the medial collateral, you can imagine now how it will be for each of the ligaments of the knee, which we have seen minutes before. And it also depends upon the structures that are attached to it. So next to medial collateral, eventually the capsule will get injured. So initially patient will feel instability, medial side giving way. Okay, whenever the subject typically has a flat foot and the genu valgum is there, subject keeps the foot, it will be a giving way medially. Okay, the knee will be going more medially. That is typical description. And you will find that giving way sensation will be there when the knee is slightly bent, the loose back position, not when full extension is there. And full extension, capsule. So that comes as a progression. So initially medial collateral, later it becomes the medial capsule. When medial capsule strain or injury happens, that is when that effusion sets in. The more fluid collection. Okay, because synovial membrane, capsule attached to the medial collateral. Only medial collateral ligament injury will not cause effusion. It will only cause medially only swelling. What is the difference between swelling and effusion? Swelling is within that structure, intracellular. Effusion is intra-articular. That is synovial fluid increase within the joint. Edema, it is extracellular fluid, lymphatic. Swelling and effusion will be associated with tenderness. But edema will be associated with tenderness only in a rare case of cellulitis, inflammation of the fascia. And the next one, what you have to see here is the patient has an effusion after a valgus injury. You can be clear that there is a capsular injury. Okay? And patient has only swelling. You can be clear that must be the medial collateral. How do you differentiate a swelling and effusion on clinical testing? Of course, effusion is full joint. So, even when that swelling is medially there, you press medially, laterally it will become blowing up. It's like a balloon. You press lateral, medially it will be blowing. What is called as the fluctuation test, ballotment test, like patellar effusion, peripatellar effusion. Similar thing will happen in the knee joint line. So that means you are pressing one side, the other side fullness will come if it is effusion. If it is swelling means you press this side, only pain this side. Other side there will not be any fluid that is coming here. Okay, so that is the differentiation. Also, clinically you will use the anatomical knowledge because you do functional palpation. We just don't palpate the medial collateral from medial epicondyle to the medial epicondyle of the tibia. We palpate and then we say it is MCL injury. No. Okay. The fingers are palpating, do the 20-degree knee flexion and do a valgus during the palpation. The function of that ligament has to be reproduced in palpation. That is functional palpation. The function of the muscle tissues should be activated. Muscles should be contracted during the palpation. Then it is functional palpation of muscle. And you are getting a tenderness medially, and during SLR it is paining, or neck flexion it is paining in the slump test. Can happen. It can be the saphenous nerve, neurodynamics. You are not looking at a ligament palpation or medial pes answering tendon, because we have three muscles joining at the pes answering tubercle medially: sartorius, semitendinosus, and gracilis, STG. So medially it is there. Vastus medialis is there. Adductors are there. So medially lot of muscles are there, including even medial head of the gastrocnemius. So remember that whenever you palpate and if the tenderness is at adjacent areas, you need to immediately differentiate functionally. You don't need to do a special test. If in AOMPT, what special test do we do for medial collateral? We do two things. Patient was riding a bike, okay, and he kept the foot down, femur adducted, and then he got the injury. So that means it is closed kinematic chain injury, the femoral component of the medial collateral ligament likely to be injured. So what we do is, we abduct the femur and see whether it is relieving the patient's symptom. And we check it in the weight bearing position of the foot, because that is the pathomechanics, the injury mechanics. Foot was on the road and adduction of the femur. That was the injury. You don't have to again do a valgus test, because David Maggie tells that. You will make the grade 1 to grade 2 injury. Maggie tells, alert the patient that my testing will provoke your symptoms, and then you perform the test. Is it a special test? Okay. What is special? It has to be totally pain-free, and the test itself should guide you for treatment. That is the special test. Orthopedic special tests are confirmatory testing before surgery. AOMPT special tests are confirmatory tests for treatment parallelly. So we do abduction of the femur in the weight bearing position and see whether it relieves. Okay, so that's the first test that we do, because we are reversing the pathomechanics and seeing whether the patient becoming better. This is also diagnosis. You imagine if you are a patient, if a therapist is telling your pain will increase, I am going to do the testing means, will you tell them do the test? Okay. So please understand that performing arthroscopy, performing ligament reconstruction is not alone the only treatment. Right, so we are starting the part 2. I was citing the example of medial collateral ligament, how pathomechanics can be a vital tool in our decision making for assessing the patients. The reversal of the pathomechanics should be the assessments. Okay, so that means you should not again reproduce the discomfort or the pain of the patient. You should use testing that will relieve the patient's symptom and also improve the functional performance parallelly right on day 1. That is what AOMPT envisions by using pathomechanics. So we would be now having, so let's wait for them to connect back so that we can resume the medial collateral ligament injuries and the pathomechanics, of course. Okay, because I want to show you the depth of the knowledge and the understanding. I can easily talk about all the ligaments and speak within 45 minutes and say that pathomechanics of knee ligaments are over. Okay, and people who are listening first time will hardly interpret anything that is what is going on. Where are we? Okay, they'll be lost. Okay, so I want to make you understand that the same picture goes to every ligament of the knee. I will talk about kinetics when, of course, Sujanya also joins. Another attempt to add her. Dr. Dharamveer, sir. Is my audio and video clear, sir? Dr. Dharamveer, are you able to join on the screen? Yes, sir. I'm audible, sir? Clear? Am I audible? Yes, okay. Ritu ma'am is typing yes. Dharamveer sir is not on front of the camera. Okay. So, yes, of course, I am seeing the request. I am approving. Dr. Sujanya is not able to join. Yeah, Ritu ma'am is on screen. Munching something yummy. Okay.
I'm doing my lunch now.
Munching the lunch.
I forget that I have not taken my lunch.
Oh, of course. Sometimes even I didn't take the lunch. My reason was different. During the practical demonstration, I don't want osteochiro demonstration becoming an obesity demonstration. Okay? So I thought I'll have the lunch after the demonstrations. Okay. So meantime, I took something light, and that's always fine. Right? I think Dharamveer sir is not on the screen. So Sujanya, I have given the invitation. I think she's not yet able to join. Okay, right. So we continue with the MCL, and so I have told you about the testing. The one component where injury is from the proximal end, the closed kinematic chain injury, foot is planted, and adduction. Okay, and adduction of the femur injures the medial collateral. So it's the femoral fibers of the medial collateral ligament. Okay, injured. So what will be our assessment? Keep the foot planted, do abduction, and see whether it relieves the symptom and the giving way sensation becomes lesser. Okay? Because the patients will have during squatting or sit to stand, although he was riding the bike, which is also 90-degree flexion, sit to stand is also 90-degree flexion. So their giving way sensation will be there. Same closed kinematic. So we can recheck the related pathomechanics. Give the abduction to the femur, either using a mobilization belt, and recheck the sit to stand whether it is better and the patient is not feeling that giving way out of control the knee joint is going. Okay? So that is one important part of assessment, the reversal of the pathomechanics which led to the injury. That should be the special test because that is treatment also parallel. The second thing what we test is, although the mechanism of injury is a valgus, okay, where the tibia is fixed and femur adducted, okay, valgus, we will check the posterior glide of the tibia or anterior glide of the femur, because we know this is MCL direction, so it will be provoked in anterior glide of tibia or posterior glide of the femur. So we are doing the reversal by doing the anterior glide of the femur. Or the fibers are like this, and I already told you that it is tibial external rotation, it will strain the tibial fibers of the MCL. And femoral internal rotation will strain the femoral fibers of the MCL, medial collateral. So there what we do is, femoral only was the mechanism. So what I will do, external rotation of the femur, which will relax the ligament, it will not re-injure the ligament. And external rotation of ligament, femur, you are not going to give MWM. You will use the external rotators of the hip because they are stabilizers of the hip. Understood? So if I am doing an adduction force for the femur, you want an abduction, you can even activate the abductors of the hip. Active stability, the kinetic chain. And giving a mobilization belt or giving a push with the hand when the patient is doing a sit to stand is a passive force, which is the kinematic influence. You can use the belt or you can use your hand. Okay? Mulligan's mobilization with movements is also based upon similar principles. So you are not checking what exactly happened in the injury, you are not reproducing the symptoms, you are not making the condition to be worse. After that you keep ice pack, compression, protection, elevation. No. You are not going to do the special test just because it is in the textbook mentioned as special test. You are going to do the real special test of AOMPT, that is relieving the symptom, making functional performance better. If it is balanced, unipedal stance, one leg standing. Because of valgus, instability is there, medial giving way is there. That means you are correcting femur and checking the unipedal stance, either passively or actively. So this is what we follow in functional neuromuscular stability training. But in that approach, I have told like it's a trial and error. But if you know pathomechanics, it will not be trial and error. You will know which muscle to activate, which rotation you want, whether passive rotation you want or active rotation you want, muscle contraction. That is where you as a clinician gets the justice. The other factor which I already told you anatomically for the medial collateral ligament, the direction of fibers itself, synergistically is the anterior cruciate ligament. So anterior translation also, this is a supporting for the ACL. So that is where you have to assess the anterior cruciate ligament also to clear that That again has to be reversal of the pathomechanics, not the pain provocative. Do not stretch the ACL in your assessment. Do the reverse. Push the femur anterior. That will relieve the symptom. So similar way, now we come to, of course, we've seen capsule injury, ACL injury. The next one with the medial collateral ligament associated injury is the medial meniscus. Meniscus, there are different types of tears: anterior horn, posterior horn, and bucket handle tear. An anterior horn gets injured in hyperflexion, anteriorly stretch. Okay. Posterior horn gets injured in hyperextension. Both the horns are in the center of the tibia, where the cruciate ligaments are attached. So you get anterior horn or posterior horn injuries together with the cruciates. Whereas the bucket handle tear in the medial collateral will be like this. Medial meniscus is like this. Bucket handle tear means it will become, okay, so like this. So that happens when the capsule or the MCL is injured. That is purely because of rotations. It's not because of hyperflexion or hyperextension. That is meniscus. We are not seeing meniscus individually. I am telling meniscus as a coexisting injury to the medial collateral ligament. Okay. So try to get the picture more deeper and see that when you apply the pathomechanics knowledge, the next part what we come to the medial collateral ligament alone is the pes-answering tendon, because medial collateral is like this, pes-answering tendon, all three are coming like this. So that is the active synergist to the medial collateral ligament. And medial collateral ligament resist against the external rotation of tibia. Okay. As valgus and anterior translation, it's also external rotation, it will resist. Somehow you have to memorize this. These are very, very essential things. If you don't have a model lower limb, everyone has spine and pelvis, they don't have the full skeleton. Okay? They think upper limb, lower limb is very easy. But you need to visualize and you have to understand. Otherwise, you just see the X-ray, see the MRI. You are not a radiologist. Okay, you are a physical therapist. So physically, you need to know. That's why these models are very useful. Okay. And external rotation, medial collateral ligament stabilizes. Think of which muscle is internal rotator. There are three muscles, pes-answering tendon. Which is internal rotator? Are among the adductors, gracilis is coming to the medial. Adductors are always internal rotators. So you can confidently tell gracilis is the synergist of medial collateral. So if you train gracilis eccentrically, it will stabilize against the re-injury of medial collateral. And the same way sartorius, whether internal or external rotation of the knee, tibia, will externally rotate. Semitendinosus, medially it will rotate the tibia. So among the pes answers, semitendinosus and gracilis both are medial rotators or internal rotators. Because of that, they both are considered to be synergists to the medial collateral ligament. So you train them for eccentric control. Eccentric control is not just that you put the TheraBand and then you keep doing the exercises. Joint repositioning error with that muscle active, which we have demonstrated in the FNST, the Functional Neuromuscular Stability Training course. How with eyes open, eyes closed, how we keep the transitions and random repositioning, how we train. And we don't just train the knee, we train hip and ankle all together as lower extremity, kinetic and kinematic chain integration techniques. Because this is closed kinematic. functionally when the patient is walking or stair climbing or squatting. It's not open. Open kinematic, you can treat only the knee joint. Yes, you have done your part. Okay, because closed kinematic, there is no symptoms. It's fine. Maybe structural problem is there. There is no functional effect. Okay. So try to get this picture clear. Also, do not forget that external rotation of tibia is actually the locking mechanism of the knee. And medial collateral ligament controls the locking so that hyperextension will not happen. And also, which muscle is a internal rotator, which is unlocking of the knee? Popliteus. So popliteus muscle in the posterior aspect of the knee is an internal rotator. It is also synergistic to the medial collateral. And always remember, short muscles will always act as stabilizer. Long muscles, two joint muscles and all are mobilizers only. They'll produce movements. Okay? So that is the same which will happen compared to gracilis and the tendinosus, semitendinosus. Popliteus will support the medial collateral ligament. Situation where popliteus is weak. When it will be weak or tight? When tibia is internally rotated, it will be tight. Once it is tight, it will become concentric underactivity. That is what we tell as acronyms, CUT and LEO. Concentric underactivity in tightness. That is specific to muscle dysfunction pathomechanics. We are not going to see regionally. Okay. So, you know concentric underactivity. So, weakness comes in popliteus when it is tight. So, internally rotated. So, internally rotated tibia, what will happen? It's an unlocked tibia. So, knee will flex. Moment knee flexed, MCL always will be strained. Giving way sensation will be more. Popliteus tightness with the weakness, concentric weakness, leading to knee flexion moment. It can even lead to patellofemoral pain because knee is in flexion. So associated compressive forces on the patella will be more. And the rest of it, you know that it can actually affect the medial collateral ligament also. So remember that even if popliteus is internal rotator, so medial collateral ligament has to be relaxed, na? So why that will be injured? You might think. But remember, ligament is relaxed for a longer time, it will lose its proprioception. The mechanoreceptors of the ligament will become deactivated because it is always relaxed. It is not loaded. So that also will create, when the challenge comes, the ligament won't be able to elongate and stop at the mechanoreceptor activation. That is, which is called as proprioception. So because of that, it goes for an injury easily with a trivial episodes of anterior translation of tibia or external rotation of tibia or a valgus. Trivial episodes, it might get injured because the ligament was not at all loaded. It is not adapted to the stretching. So that is the reason in ligament injury rehab in the later phases, we load the ligament. We want the genu valgum. Okay? Because functionally, how much ever the valgum can come, it has to be maintained there. That is when you have rehabilitated the subject adequately enough so that they can return to activity and recovery to unrestricted function, which might take around 3 weeks to 6 weeks depending upon the extent of the tear. If it is full thickness tears or associated injuries are there, capsule, meniscus or ACL, definitely requires a higher level of surgery and the reconstruction of these ligaments. Of course, the rehab will, the duration will depend upon whether you want an accelerated rehab or you want a standard rehab protocol, but the mechanics will remain the same. The application of whether closed kinetic kinematic or open kinetic kinematic, which principles you are using to rehabilitate the ligament. Not just structurally giving a deep transverse friction massage, but also functionally training the joint for the proprioception, microreceptors, threshold reductions, and the synergistic muscles versus antagonistic muscles. Synergistic muscles should be trained eccentrically, whereas antagonist muscles have to be you have to choose the stabilizer, the one which is the shortest muscle. So that is the stabilizer. So train those muscles isometric, because stabilizers are for postural control. So that is isometric endurance. Right. So we'll listen now from Ritusani ma'am, who of course would have seen that only NCL can it have such a extended picture. Okay, so today's thing definitely would have enhanced the depth of the pathomechanics that is actually needed, and knee joint is the best to actually explain. And we can have added sessions depending upon our members' availability and the after completion of the 25 webinars. But remember that this is something which will actually make you the best clinician in front of your orthopedic surgeon, because you can describe all this and discuss, interact, humble manner. Do not argue and show off. Knowledge never goes behind people who are arrogant. Knowledge always surrenders to people who are humility. So yes, ma'am.
Yes, sir. I think as we talk about the pathomechanics of lower limb, yes, as a biomechanics, we focus on the knee joint, because which is already you explained that how the ligament support is very, very important. If the patient is having a instability of that ligament, it can cause to the injury, either itself because of the instability or because of sudden injury, in which we see that as a sports person, they are having a ACL injury, PCL injury, and not only that, the people who are having the degenerative changes, that time the because of the reduce of that space in between the condyle space is reduced, and then the medial collateral ligaments, normally we see more than the patient with the medial collateral ligaments, they are having a problem. So what the mechanism you have explained today about the medial collateral ligament, it has given us the view that why the patient is more than the patient in 100 out of 180 patients say they are having a pain in the medial side, because of that valgus stress, the force which is giving them the stress, and as the open versus the closed kinematic, where the tibial external rotation and internal rotation plays a major role, and as well as the femur abduction and adduction plays a very major role. So which mechanism, because we know that as a closed kinematic, we see that how the femur is moving. So that is very first step in the pathomechanics we see. And if the patient is having an injury as an open kinematic, when they are doing some exercise, they are running or they are doing cycling or whatever, like they are kicking the ball. So that time they feel they are having an injury related to ligaments, either in the medial side. So that time the open kinematics, we focus on the tibial rotation normally. And as our MMPT protocol, yes, we check with the opposite direction, that how with the if there is a tibial rotation is causing a problem, so we check with the femur rotation also, so that we see that either it is a relieving factor or aggravating factor. This is very important as a pathomechanical part. And also the locking itself of the knee, we see in our old age patients, they are having a problem related to the locking of knee. So that time also the mechanism how with the external and internal rotation of the tibia in the flexion versus the extension position, that time also how medial collateral ligaments which play either in the stress position or it is in relieving position. So that is also very important, as well as that how the meniscus also give adding a point to that injury by creating an injury in the menisci. So that is also important, and as well as how we see that the very best example, or very easily you have explained that how the small muscles, they are the stabilizer. So how the popliteus area, we check the popliteal muscle that give the stability to the knee joint, as well as like we see the soleus that gives the foot stability. So that is the stabilizer there also. So these are the stabilizers which play a very major role when there is a ligament injury, either the open versus the closed kinematic. So we cannot see that only we are going to see the kinematic part when there is an injury. Here you have added that with the kinematic, what is the kinetic force which are either aggravating or which muscles are in the relieving portion. So where we have to work either on the muscles which are giving in the, we can control in the trained in the eccentric position or as well as the concentric position. So that is also, I think, the internal rotators which you have mentioned, that how we check with the gracilis or the sartorius, they as a add-on point, or the semitendinosus that is also with the medial side is coming in the picture. So these are the things where we have to work on the adductors for the hip training, also with for the with the knee with the femur rotation, or the abductors that needed with the adduction force or abduction force of the femur. So this is the way I think the knee ligament only the MCL can give us so many clue for treating our patient. So what is the picture of the other ligaments will be, which is more useful to check the ligament injury in the knee problem. And in our, I will say, very best course of AMPT, if I am not uh, wrong, that was the instability course. Our instability course that has in all the parts where the ligamental instability plays a very major role. So in that you have shown all the ligaments of the knee itself, that how these ligaments plays a very major role when the patient is having a injury related to ligaments, or the after that this injury leads to the capsular injury. So how that is also loose packed or close packed position, we check with the ligament to the capsule. That also very important part here, because first we see that ligaments, then further we move towards the capsule. That is also to check the injury, that is important part here. And I will say that for the simple MCL word itself, you have mentioned so many things, either the nerve, the neural component is also where the saphenous plays a very major role, and the articular part, that is very as a ligamental capsule also, menisci, that cartilage tear itself, or as a myofascial component, that is the pars ansris which you have added. And simultaneously we have to whenever we treat as a myofascial component, we have to work on the antagonist muscle also. So that also plays a major role, like we see with the IT band, and we see that Gardis tubercle, that also plays a important role whenever the medial side injury. So we go and train them also as a antagonist muscles. So this is the way as a full picture we have to see that how we can give better treatment with the understanding of the pathomechanics, why my patient knee is not coming in the flexion position or not coming in the extension position. So what is the role here, the tibial rotation, external and internal rotation, or maybe the lower kinetic kinematic chain, where the foot pronated foot versus the supinated foot, that can affect the tibial rotation also, and their movement itself with the talar joint. So these are the things I think very important, which you have mentioned in a very crisp way in the very short period of time. You have shown a full view of injury related to the knee. So thank you so much, sir. And definitely this webinar, the people who are enrolled, they will get the video. They have to see. I think I will also see twice and thrice, because this will clear so many doubt, and this will clear me how to treat my patient who are having a medial side pain in my patient. That will show me the view. This is the G map which you have shown for the knee recovery, and definitely it will be very helpful for me, because I am facing some stucking with one of my patient. But after today listening you, I got some point that yes, this point I was missing. Definitely, I will see towards it and I will treat my patient. So thank you so much, sir. And definitely, it's worth watching and listening to this pathomechanics session. Yes. Over to Dr. Dharamveer, sir. Yes, sir.
We are about to have the practical session, and unfortunately, I think the model is not able to come today. Okay.
No problem.
So then I felt that okay, we continue as part two.
No problem.
between there was a data interruption, and then we had this session. Sujanya couldn't join, but we could take this session in this evening because it's very important. It's not just a Founders Day. The day has to actually make people to find within themselves which are the areas where they can improve, which are the areas which they can capitalize on, okay, which they are stronger actually, which you can invest and you can create a better outcomes on patients or in education. And finally, it all boils down to the professional dignity, the identity what we receive in return, be it from the patients or from consultants. Okay, so in the best way that is possible, we have done even anatomy courses, the fellowship in musculoskeletal clinical anatomy, where each and every ligaments were attached, okay, between these bones using kinesiotapes, and the same kinesiotapes were again stuck on the human model related to the surface anatomy, and assessment and treatment implications were also discussed together as clinical anatomy.
Very true.
So it is like anatomy extending to the extreme is clinical anatomy. From there is the pathomechanics thinking. At the end of clinical anatomy is the beginning of pathomechanics. Okay. So both are like, if I have to say in the present scenario, like Ritumam and Darshana. Okay. So it is like one is there, another not there. If other one is there, then madam will leave. Okay. So yes, you are there now. Okay. You sit there in front of sir. I will go come back. Okay. So that alternating thing. So structural problems, although the structural damage is there, your goal has to be functional. Okay. Even if it's the 3rd degree tear, there's nothing wrong in functional training. That is why we are going to follow in an elderly patient who's not going to be operated. Okay. And rest of it, the functional neuromuscular stability training. So that should be there. Because you can combine mobilization with movements, you can combine the muscle activation, inhibitions in a functional activity, so that the functional activity which was painful or giving way becomes better and the endurance improves in the patient. Okay. Right. So good that even Dr. Sujanya is watching and she is commenting. Okay. So whether the internet problem happens in Delhi or it is at Sydney, I'm not sure, but still, okay. It's a important day where we had many things happening in this one evening. To top everything was, of course, Dr. Darshana's address, okay, when she spoke to all of us, and the confidence that she has. We see the actual Darshana again back in action. Okay, so something like a happiness, which a learner like her is duly blessed. Okay, and the destiny is just waiting to provide her more and more opportunities to explore her own self, so that she can manifest it for the betterment of the world. Okay, so right. Okay, so Sujanya, like anyway, people in India will think that being in Australia itself is a good luck. Okay, and then after that, in Australia, owning a clinic is a good luck. Okay, and being in Australia and learning from India, that is good luck for the AOMPT. Okay, and the next level is, of course, the gift water, because of the collaboration that the clinical associate and the partner where recovery rehab physio of Dr. Sujanya is co-certifying our AOMPT courses, so that our COMT graduates, they are proud to put COMT in Australia. Okay, so this is something which is a great development that happened this month, and it is not about the birthday, but it is always rebirth of yourself every day. Okay, keep getting born every day. Okay, There will be situations which will destroy you. There will be challenges that will block you. But when you come out of that, you are actually having a birthday only. Okay? So the happiest birthday has to be there for every one of you. Not just today, but every day of your life. And ensure that the crying baby, we tell when the baby is born that when it cries only, others are happy. Same like that, you be the crying baby, so you get all the milk of knowledge. Keep that baby's energy that unless I get my knowledge, I will not stop my crying. That drive of getting the knowledge. Not like I don't have knowledge, so you cry. Okay, that is depression knowledge. But this is a motivational cry. Okay. So absolutely, every one of you, you are all unstoppable, and you can do the best for our country, in making India proud. And I am very sure that all you guys will make the womanhood proud, not just the physios. Okay, because you have taken multiple challenges parallelly, and you have learned so many courses. You are supporting each other. That's the best thing that I can see on my birthday, actually. Okay? So it is great, actually, to be associated with all of you, which I always, during every Navaratri, I tell that. Okay? So I always tell that FemCon, when we had also, it is the women physios who are actually the greatest inspiration for the academy and the power girls of the academy. Okay? We have Dr. Sujanya, Rituma, Dr. Dashna, okay, and Dr. Chaitanya. Every one of you, you are all reborn. Okay? You are not like as if you have got 15, 20 years of clinical experience. No. You are seeing yourself as your first year PPT or second year PPT. Okay? Any topic when I tell a new information, immediately you become a first year PPT. Okay? So that is something which is amazing. And hats off to you all. And let's close the session with wishing the best for all of you. Good luck.
Thank you, sir. Once again, happy birthday. And good luck to all of us, not you, to all of us, because we are blessed that we are learning from you. And definitely we feel proud as a part of the UMPT. I don't know for others, but I feel that this is my rebirth when I joined the UMPT, and I am learning and learning. So this is really, I cannot think in my post-birth, I cannot think that was the possible thing, but now it is possible because of you, because of AMPT, because of your classes. Because whenever I texted you, sir, I want to learn this topic, within a second I have seen there is a flyer that yes, we are coming with this course. So this gave me that whatever the topic I stuck in the book, so I think I will not study from the book, I will study from you. So I just say that I will say to sir that I want to learn it, and within a second we are ready for the next session on that topic. So this is the thing which if we want, you were also giving, because this is a simultaneously from both the side, it was give and take. I will say it was going on that we want and you were giving. So this is the thing, either you are pouring your milk or whatever the things as the form of the knowledge, but we are the receiver and we were getting continuously. And for myself, I will say that I am receiving from last 3 years continuously from you, because without AMPT, I was nothing. So this I can say proudly and confidently. So I have seen a change, like the Darshana ma'am was, see that I was doing competition from, I compete with myself. The same thing that I know that how I improved because of your knowledge, because of your teachings. So that has changed my life fully. So I don't know that how many patients I can treat in a day, whatever the number. But it gives me a happiness. Whoever come, they becomes better. They give blessings. They are happy. So that gives me that yes, I am on the right path. I am learning from the right place, which is getting me confidence day by day to seeing my patient. Even the patient who was sitting so many kilometers far away from me. He was just telling, there was no video call. He was just telling his problem to me on the phone. And I was thinking that when he was explaining, I was making diagram in my mind that at what place, what is the connectivity of his problem as per one of session in the tele rehabilitation you have explained. So the same thing it was going on in my mind that yes, I have made the diagram and I whatever the points I was telling him that is this the place? Is this the first step? Is this? Then he was saying, yes, ma'am, it is very correct that you are mentioning very right place where I am getting pain. And that case was related to that visceral to somatic. So how it was the viscera which was creating the somatic problem. So that was connectivity I was making in my mind. And it was completely correct that what the map I made with his listening. So this is only because of, it is possible because of you. Nobody can explain in such a depth that how I can learn it. It was not possible for me before the AOMPT. So thank you so much because this day, today's day, very special day for all the AOMPT member. And it is very, very special for me that because it is your birthday, it's the founder day of AOMPT and it is the really a founder day for me also. I found myself on that day. So this is very special for me. So I'm wishing myself also for this day. So thank you so much, sir. Thank you so much. Again, thank you. And thank you,
Only,
Sujanya. Yes, sir.
yeah, I only hope that after this webinar, Dr. Sujanya again will be tempted to take the ligament injuries course or the functional neuromuscular stability training course. Okay, because every day she's taking courses. Okay, so it's amazing to see such a passionate and a serious learner. Like, my life is not important if I am not learning. Okay, so something like that. It's great to see, and the support that she receives from her family and the beloved children, okay, including the two who were present in our cake cutting, Theodore and Rishi. Okay, for that, somehow they are all allowing her to, learn, be away from home, okay, go out of home, come back, okay, everything. Still they are happy, because if it was not for them, it's definitely tough for a woman in a family, okay, to actually rejuvenate or recycle yourself and then come back to be the best of yourself. Okay, right? So, good luck and enjoy your time in the evening today, and we'll meet again tomorrow. Of course, the Pathomechanics course, again there is a big question mark because the boy has to come. So, but I have one enrolled participant who wants to attend offline, so but he unfortunately refused to be the model for today. I just called him, okay, so you come, but he stays 45 kilometers from Bangalore. But he said I cannot be model. Then I told, don't come, okay. If you are coming here, you be model, okay. That is the use. He said my wife. This some stories he was telling. I told, okay, that is your personal problem. No need to tell me. So then after that, I told him today don't come, na. Then he is telling tomorrow I'll be the model. Okay. He is enrolled both days. Okay. So he is coming. So if he is around, definitely we can have these 2 days fully with clinical pathomechanics, which is I can say enough of brainstorming. We create fire, but the main, you need to have that course. Okay. So let's see whether we have tomorrow and day after, or it is Monday and Tuesday also. Still it is fine because it is again the weekend only it comes. Tuesday is a holiday again. So let's work out how it goes. If this boy today who is supposed to come, that boy comes tomorrow also, I am ready to take it and get on with the sessions. Okay. Right. So see you. Bye bye. Great ma'am, Dr. Sujanya. And we'll get back with more interesting topics, which are the remaining ones of the clinical pathomechanics webinars. We covered them before the Kolkata clinical COMT, okay, at our own leisurely place. Because the last of the pathomechanics, clinical pathomechanics, is thoracic cage in pulmonary dysfunction. So that is actually suited for the Pondicherry course of pulmomanual therapy. So we'll take it closer to that. So we keep scheduling like this so that it helps that coming offline courses, the subsequent participants to get benefited. Okay. Right? So see you. Bye bye.
Bye, sir.